So I'm Gabriela Kraiter, and this is my case presentation. So I have an 18-year-old male, history of right ptosis starting back in May of 2021, a COVID infection that year that was relatively mild, complicated by a rash. And then 4 weeks later, developed onset of a progressive neurocognitive decline characterized by this progressive somnolence initially, and then by November of that year, started developing short-term memory loss and eventual decline in motor skills. He presented to VCU where he had a prolonged and complicated hospitalization where he was found to have this left-enhancing basal ganglia lesion that extended into the thalamus, septum pellucidum, and temporal lobe. There, he had workup with an initial LP back in November that was essentially unrevealing, no pleocytosis, and ultimately had a brain biopsy in December where biopsy of that left paraventricular area showed extensive perivascular chronic inflammation, but no other notable findings. Even though there was a lack of pleocytosis or evident antibody in his CSF, he was empirically treated for possible autoimmune encephalitis at this point. He received IV steroids, cyclophosphamide, and Plex, but unfortunately, there was no improvement clinically. He became more somnolent with progressive difficulty awakening to the point that he was ultimately nonverbal. And then MRI showed no improvement and possible progression, as we can see here. He underwent further workup to include a PET from skull base to mid-thigh that had some asymmetric uptake in that left basal ganglia area, as well as increased bilateral testicular uptake, which was really unrevealing on further evaluation with a testicular ultrasound. And he again went a repeat lumbar puncture at this point that was also unrevealing aside from now a protein elevation to 105. At this point in time, he was transferred over to Duke Neurology for consideration of another biopsy after VCU neurosurgery declined to perform a second one. And on arrival to Duke, his exam was pretty limited. He was nonverbal, but did track conversation with eyes, otherwise required repeated stimulation to stay awake, didn't follow commands, didn't communicate with body language, and was pretty non-participatory and noted to be diffusely weak. He did undergo a second brain biopsy, and review of this biopsy, as well as slides from the VCU biopsy by our pathology here, was pretty consistent with a prior diagnosis that showed this prominent perivascular chronic inflammation that did have mixed T cells and B cells without significant cytologic atypia. So at this point in time, he underwent a pretty extensive workup during his admission here with the help of rheumatology, ID, neuro-onc. He had these extensive labs that I won't go into all the details of, but they were pretty much non-revealing. So at this point in time, there was extensive discussion between neurology, rheumatology, and pathology here at Duke, reviewing the slides, reviewing the prior workup, and working diagnosis of CNS vasculitis was made on evidence of this extensive perivascular inflammation and absence of any other etiology from the extensive workup that was done. And although considerations could be made for perhaps an autoimmune encephalitis or some other unspecified inflammatory disorder, lack of pleocytosis in his CSF or other evident antibody argued against this. So treatment-wise, he was restarted on high-dose steroids and initiated on monthly IVIG and infliximab. Of note, they deferred repeating a second dose of Cytoxan, given that he had complications of neutropenia and hemorrhagic cystitis from the first dose, as well as the fact that the primary immune cells that were present in the flow cytometry of lesion were actually T cells, with a much smaller population being B cells. And in that setting, a T cell targeted therapy like Cytoxan or like infliximab was favored over, say, B cell targeted therapy like rituximab. And then at this point in time with treatment, there was a gradual improvement. Clinically, he did start opening his eyes, moving extremities spontaneously, ended up engaging much more with PT, and radiographically, there was interval resolution of that patchy area of enhancement. This is the most recent scan, and then this is his prior scan for comparison. He was ultimately discharged to Wake Med Acute Rehab on Pred taper and planned for monthly IVIG and infliximab. And chart review seems to show that he's continuing to progress, where he's intermittently standing, has weaned to a diet, and has started to interact a little bit more, smiling and using communication apps. So I wanted to talk a little bit about CNS vasculitis and infliximab. As we all know, vasculitis can be a challenging diagnosis to make. Imaging, serology, and CSF can fail to establish a diagnosis at times, and even a negative brain biopsy doesn't rule out an isolated CNS vasculitis. In these cases, it's important to have a high index of suspicion, especially when you have progressive nonspecific neurologic cases, and immunosuppressive therapy can result in clinical improvement and stabilization. Touching a bit on the role of infliximab, there are case reports of CNS vasculitis where patients that have failed conventional first and second line therapies, like the ones listed here, eventually do find remission with infliximab. And it is considered the treatment of refractory systemic vasculitis, with additional considerations being given in cases where histological slides do show a primary lymphocytic vessel wall infiltrate, as was the case for this patient. So ultimately, even though the diagnosis was a pretty difficult one to make, the treatment ended up being the right answer for him, which was fortunate. And that's my presentation. Any questions?
Well, this will be the first time ever. We'll take a question on the case because Gabby did it so concisely and beautifully. Bill, you had a question?
Yeah, I would say that this actually seems much more consistent with Behçet's disease than CNS vasculitis because it was perivascular inflammation, not inflammation of the vessel wall. And plus that particular localization at the top of the brainstem and the basal ganglia is actually really characteristic of that condition.
Wow, that's a great consideration. I'd have to look back and see if that had been considered.
Yeah, because I mean, you know,
that's a really good point.
Yeah, because with vasculitis, by definition, pathologically, you actually have to have inflammation in the vessel wall, not perivascular. But Behçet's is classically perivascular, perivenular, and it really looks very, very, very much like that. Now, that's fine because the treatment's the same, right?
Yeah.
Gabby and I concluded that it was a infliximab responsive process.
Right.
Yeah, so that diagnosis was, this is Joel, that diagnosis was considered and he had no other ancillary things to go with that, which doesn't rule it out. And that was basically our conclusion, was that the treatments were going to be the same. So,
in any case,
appreciate your comments.
Very lucky to have had Gabby taking care of him because he's doing well. And we were lucky to have her do such a concise, that slide when she showed it to me yesterday, the slide of tests, I thought we wouldn't have time for grand rounds once that thing went up. All right, thank you, Gabby. Great job.
Thank you.
Great job to everyone who took care of this patient. So today we have two people doing grand rounds. Emily O'Brien, who is an associate professor in population health and a former Duke undergraduate who got her PhD at UNC, and Jay Lusk, who is a Duke medical student who's also getting an MBA in Fuqua as part of his undergraduate. And I think Jay's getting a PhD too, which I don't see here. He's soon to...
Rich, are you sharing slides?
No slides.
Okay, perfect.
Winging it. Soon to graduate, right, Jay? When are you coming back to the wards?
On Monday, starting my neuro sub-I. Looking forward to seeing many of you all on the wards.
No more Zooming. Okay, so they're going to talk to us today about using Medicare and Epic database to look at disparities in neurodegenerative diseases. And I'm going to turn it over to the both of them and they can orchestrate it.
Sorry. Okay, can you guys hear me okay?
Yep.
All right, and can you see my slides?
Nope, no slides.
No slides? See.
Will, do you see them?
I do not.
Okay. There we go.
Okay. Yep, there it is.
So Emily, just go into the presentation mode. We're seeing like practice mode.
Ooh.
Just go to the little screen at the bottom.
Okay.
Right.
Maybe I might ask Jay. Jay, if you have them, can you share, because my computer's doing some strange things.
Yes, let me do that.
Okay.
Okay, Jay, we got yours there. There we go. That's good.
Great.
Yep. Okay, great. Thank you. All right. So good morning, everybody. Thanks so much for being here. I'll give an overview. This is really sort of maybe a philosophical or just a high level sort of methods overview of how we think about using observational data for research. And then Jay will dive into some of the recent work that we've done, as Rich mentioned, using Medicare data to look at some disparities in Alzheimer's disease. Okay, so we'll go to the next slide. And these are my disclosures. Okay, so I guess, the other disclosure I have is that I'm an epidemiologist by training, and I've really spent my entire academic career so far working closely with clinicians. I really think this is the best way to do clinical research, and that we have a lot to learn from each other, of course, but also acknowledge that, there is a bit of skepticism that sometimes underlies that relationship. Certainly some cultural differences. For those of you who've spent time in both worlds, you've probably seen those firsthand. In epidemiology, we use a lot of observational data. And in my experience with clinical trialists, there's often this view that randomization is king, and anything that's not randomized should be treated with a lot of suspicion. So I just wanted to acknowledge that up front, and then hopefully demonstrate the value of observational data, certainly for the type of descriptive work that we'll talk a little bit about today, but also get us thinking about how to use it in a robust way for comparative research, which is a growing area here at Duke and more broadly. Okay, so first let's start with this question of why should we bother? I'll move through the first 3 bullet points pretty quickly, and then spend the bulk of the time talking about what I think we can do better here. Okay, so go to the next slide. So those of you who've been in sort of health system-based research for a while know that about 15 years ago, we started talking about this concept of a learning healthcare system. And this sounded really promising at the time. We have electronic health records on the horizon, and these are being rapidly adopted. We'll be able to use them for everything from disease surveillance to following up people in clinical trials, quality improvement. The Institute of Medicine held a roundtable on this topic and predicted that by the year 2020, 90% of our clinical decisions would be supported by accurate, timely, and up-to-date clinical information. All of them would reflect the best available evidence out there. And certainly, I think we can all acknowledge that this has not come true yet, but certainly, we have this tangible focus for our progress towards this vision. And really this idea that we should expect at least this level of performance. It should be feasible with existing resources, with the data that we have, the methods that we have, the analytic tools that we have. And although it's out of reach currently, it's something that we certainly should be shooting for, and that we can achieve at some point. Okay, so you can go to the next slide. So, clinical care, of course, is just one aspect of population health. Unfortunately, we also see some disheartening trends there. We've seen declines in life expectancy even pre-COVID, and as shown in the graph on the right, the estimated life expectancy dropped by 1.4 years from 2015 to 2022. In addition to declining life expectancy, we're also seeing increased levels of chronic pain, greater reporting of unhappiness, despair, depression, et cetera. We know at least some of the drivers of this, which include accidents, drugs, alcohol, suicides, et cetera. But we also see that there are disparities in how these patterns are playing out. The trends in declining life expectancy are especially apparent in people without a 4-year degree. And if you look at a shorter time frame, as shown here from 2019 to 2020, we see declines of about 0.8 years in white individuals, but much higher levels, 1.9 years in Hispanic individuals and 2.7 years in Black individuals. So when we consider this happening really on the backdrop of longstanding inequities, we really should start to feel pretty uncomfortable about the way things are going. And so our hope, and we hope to at least demonstrate one case study for how to do this today, is that observational data can be one method that we use to understand and address these disparities. Okay. Okay, so why should we be skeptical? Okay, so you can go to the next slide. So you've probably heard of this concept of the information paradox. We certainly have more data than ever before. But the question is, are those data helping us? I think most people who've had any experience with analysis of these data would say probably not to the level that we thought they would be, or that they could be. Our ultimate goal, of course, is to see the signal through the noise and to get to the truth within these data, which of course arrives with time and involves an iterative process. And Jay, if you can click forward, we've also seen in the past 2 years that even the greatest scientific breakthroughs run up against this challenge of misinformation. And so it's important that we keep in mind translation of research results, that even if we do the best possible work, that may not make its way into the way that people live their lives or make their medical decisions in a straightforward manner. Okay, so when we think about this quest of going from data to insight, we have a couple of choices, of course. Many people have seen some version of the traditional evidence pyramid that's shown here on the left. And this really sends the message for how much we can trust data that come from different study designs. And so there are a number of issues with this hierarchy, probably the most prominent being that it's definitely oversimplified. I think that most of us are starting to move towards something that you'll see once Jay clicks through on the right, where the lines are a little bit more blurred, and that depending on the design, some of the results from these various designs can be more trustworthy than others that are technically above them on this pyramid. I also like the positioning of the systematic review here, which is really the lens through which we see these data, rather than the top of the pyramid itself. Of course, systematic reviews are only as good as and as strong as the studies that are included within them. Okay, so the contrast between different study designs is certainly an important topic for conversation. This is true for all of us as decision makers who need robust evidence in a clinical capacity, but also as people who are trying to understand how to best live our lives and how to eat, how to exercise, how to sleep, etc. This is a table from Jerry Aborn, who's chief of the division of pharmacoepi at Brigham, and nicely outlines some of the key strengths and weaknesses of RCTs and observational studies. And some of the instances where there's been disagreement from results and sort of what they might say about the rigor of observational studies. And Jay, if you click through, you can sort of see like the vastly sort of oversimplified view of how this looks in practice. And generally what we see is increased costs with a conventional RCT. Observational studies often take advantage of existing data sources and don't require prospective enrollment, and so it can be cheaper. But then we have issues with lack of internal validity that tends to be better as a result of randomization, as well as increased generalizability, which sometimes is a downside of randomized clinical trials, which are focused on narrow study populations. Okay, and so one thing just to keep in mind is that a lot of our everyday decision making certainly is still driven by evidence from things that have never been randomized and would never be included as a question in a clinical trial. And so Jay, you can sort of click through. Certainly, parachutes, injury when falling out of an airplane, smoking and lung cancer, we know are associated very strongly and have a causal connection from observational data, seatbelts and automobile fatalities, and then unprotected sex and pregnancy. So we're living our lives in the really in the light of and as a result of non-randomized evidence, and I think we should continue to be open to the use of those data for clinical decision making. And then, from a population health perspective, of course, we care about causal effects from things that cannot and will never be randomized, right? So there's certainly lots of health determinants that are completely outside of the control of an individual or their physician. We have observational data about them. We know they influence disease. They're certainly worth studying, but we need to do it in a way that's robust, so we can really start to explore the mechanisms and identify how to best allocate our resources for interventions. So it's really interesting to see how journals feel about this. Certainly, there's a ton of variation in acceptance of causal inference from observational data. This is the sort of party line from JAMA. This is from an AMA style insider blog, and they start with this question of, is it randomized? And they say, if no, it's important to take out all cause and effect language. And so certainly, it does a disservice in a few ways, implying that randomization is a panacea for lots of other design problems that can arise in trials. And then certainly, ignoring a lot of the advances that have been made in causal inference using propensity score methodology and evolving techniques to really account for differences between treated and untreated populations. Okay, so certainly, there's this sort of polarization that exists between there being absolutely no substitute for randomization, and then this perspective that, real world data will fix medicine. And this has, certainly been much more active space over the past few years with the Affordable Care Act and with all of the work that PCORI has done and comparative effectiveness and in studies embedded within the health system, certainly. But I think that, the key here, of course, is that there's a balance between the two. We need well-designed cohort and case control studies, and we really need to get the methods right if we want to make valid comparisons between groups, including treated and untreated groups in broad populations. And I really liked this visualization that, we again think about these opposing approaches, but they're really complementary. Again, this is an illustration from Jerry Aborn, who says, these two approaches are a little bit like rocket ships and telescopes. Space flights got us to the moon and beyond, but astronomy in a non-interventional way revealed a lot of the basic secrets about the universe and really made that space flight possible. So to know everything that we need to know about a drug, we really need to do both, and we should do them both with rigor and with humility, understanding that it's an iterative process, and we need to build upon prior knowledge and certainly improve using state-of-the-art methods and best available data as we go. Okay, so why should we be hopeful? So I think I've validated the skepticism to some degree, but there's certainly recent progress, I think, that gives us some hope about the strength of observational data. This is a Cochrane review from 2014, a meta-analysis actually, where they looked at methodological reviews and compared the quantitative effects, or the effect size estimates of efficacy and effectiveness from interventions that were tested in trials, as well as those in observational studies, and really found some pretty good consistency between the two. This has been done in a lot of different therapeutic areas, but certainly one example of how things align maybe more nicely than we would expect. Okay, so I want to talk just briefly to close about some of the main opportunities, including registry-based and pragmatic clinical trials. These can vary in terms of structure, but the goals are really the same. Again, to understand the causal effect of a given therapy that is currently used in practice and where there's currently equipoise. The pragmatic designs, of course, are intended to make things more streamlined and to move from a complex design to a complex approach to a simpler operational approach, while preserving, the robust methods that allow us to say something with some degree of confidence about a treatment effect. But really add the important advantages of a larger sample, more diverse population, and potentially more generalizable results. So I'm really excited about the work going on at Duke through the NIH Collaboratory, Adaptable, and other pragmatic pragmatic trial efforts. I'm thinking about how to embed these trials within clinical care processes and use existing data instead of creating a totally parallel work stream that we have to rebuild every time, and one that really focuses on a selected sample of patients who may or may not represent who we see in practice. Again, just a quote that sort of summarizes the features of a pragmatic design, I think that really nicely balance some of the strengths of observational data as well as randomized clinical trials. Of course, even when randomization is in place, it's important to recognize that pragmatic clinical trials and explanatory trials have different goals. I really like the quote on the right, Jay, if you click through, from Greg Simon, who's been involved with the NIH Collaboratory for a number of years. explanatory trials tell you what is true and pragmatic trials tell you what to do, which I think certainly oversimplifies but nicely summarizes the thinking around how these are beneficial. And so this is just an example that I use in teaching that sort of acknowledges that, anytime that we ask a clinical question in the setting of a trial, we have this target population. The trial population is, one subset of that population that, has access to the trial, is interested in research, has, meets all the criteria of the trial, of course, and that we might end up with a very selected sample that may or may not be generalizable to this broader population. And so this is, I think, important to keep in mind, certainly when translating trial results and thinking about implementation, but also, as we think about designing trials, certainly incorporating some elements of pragmatism with an eye to ultimate clinical implementation, and thinking about how to apply those results in practice in a streamlined way and in a way that really honors the variation and really the diversity within clinical populations. Okay, so I have just a couple of take-home messages on the final slide. Observational data are powerful, and I think you'll see this when Jay presents some of what we've been doing with the Sunrise study. But we need to work with them responsibly. We need to, of course, acknowledge limitations and make sure that we're applying methods that are robust and appropriate for a given data source. And certainly, there are pitfalls along the way that we've all learned about to some degree throughout our education. I think collaboration with methodologists who are well aware of these pitfalls and can provide advice on strategies for how to deal with them appropriately is really central to success here. And that is my final slide. And I will turn it over to Jay.
All right, let me get my slides up and going, and then we'll jump right into it. So we're really glad to have the opportunity to share with you some of our work that we've done that really, I think, puts a lot of the principles that Dr. O'Brien just described into practical effect. And so we're looking forward to sharing that with you. Are those slides working?
Yep.
Yep.
Fantastic. So the overall overarching theme of our project is really to investigate racial disparities in dementia and Parkinson's disease incidence, healthcare utilization, and outcomes among Medicare beneficiaries. First, disclosures to the American Heart Association and Margolis Center, and then a disclosure and thank you to the Department of Neurology for funding this research. So this audience does not need particularly much background on neurodegenerative diseases, but I think it's clear to all that this is an impending health crisis. The most recent estimates indicate that prevalent cases of neurodegenerative disease will double to nearly 70 million by 2030, and the costs to society, including both direct and indirect costs, will double by 2040. And this burden is not shared equally. There is already clear evidence of disparities in incidence. For example, Black Americans are nearly twice as likely to develop dementia as white Americans. And there are substantial gaps in our knowledge about the mechanisms that underlie these disparities, whether that be risk factors in particular subpopulations, trajectories of healthcare utilization and outcomes following initial diagnosis, variation in healthcare access and quality, and geographic variation in diagnosis, practice patterns, and in community resources. And so we used one linked data set with Medicare claims and Duke electronic health record data to answer 4 related but very different questions, which we're going to walk through today. The first is, are there racial disparities in the incidence of neurodegenerative disease in North and South Carolina and in healthcare utilization for patients with neurodegenerative disease? The second is, how do the patterns of healthcare utilization differ in the last year of life based for patients of different race and gender? Third, are there racial and sex disparities in receipt of certain psychiatric medication prescriptions for patients with neurodegenerative diseases? And fourth, do our own internal electronic records correspond with Medicare claims data about what patients actually have neurodegenerative disease? And we're hoping that by walking through these 4 very different questions, we can illuminate a little bit about the power of observational research to provide meaningful insights to support clinical care and clinical decision-making. So our study population applies to all of the relevant questions, which is that we looked at a 100% sample of Medicare beneficiaries in North and South Carolina from 2014 to 2017. And we used validated algorithms to classify those patients as having dementia, which included a variety of different dementia subtypes, or Parkinson's disease. So let's jump right into question 1, which is racial disparities in neurodegenerative disease incidence and healthcare utilization. So this analysis included around 520,000 patients. The patients were on average about 80 years of age. Around 2/3 were female, 20% were Black, and around 80% were white. Around 4 in 10 were both eligible for Medicare and Medicaid, which is a coarse indicator of low socioeconomic status. So I'm going to describe this adjustment strategy, which is to essentially control for other variables that we already know are related to outcomes and to incidence of dementia. And these include age, gender, comorbid medical condition, socioeconomic status, rural location, which state, and importantly, county level access to healthcare resources, recognizing that if we're going to talk about healthcare utilization outcomes, the biggest determinant of patients not using healthcare resources is not having resources to use. And so we find that it's important to adjust for as we try and really drill down on the mechanism that underlies any potential disparity. So let's talk about incidence. So as you can see from this chart here, and these are incidences per 100 million person years, per 100 person years. These are as you can see, in 2014, there were fairly substantial disparities in incidence, with Black patients in North and South Carolina having a substantially higher incidence of dementia and Parkinson's disease. This disparity narrowed by 2017, but it's worth noting that even though that difference looks small on a graph, it's still large when you translate that into a population of hundreds of thousands or millions of people across 2 states. And it's still also statistically significant as well as significant on the clinical and population level. So jumping into the main results, which is ultimately, what do outcomes look like based on race? And so what we've done here is we have we've compared Black beneficiaries, Black Medicare beneficiaries with white Medicare beneficiaries, and looked at the and after adjusting for the factors that I mentioned before, took a look at what do outcomes look like. And what we see here is I think really it's deeply concerning, which is that a large variety of negative healthcare outcomes are substantially higher among Black beneficiaries. For example, Black beneficiaries are 4% more likely to be hospitalized, but we see even bigger disparities in certain use of healthcare services. For example, Black beneficiaries were almost 40% less likely to receive occupational and physical therapy, were almost 20% less likely to receive hospice services, and we're less likely to be treated with medications for dementia like acetylcholinesterase inhibitors, or for medications for Parkinson's disease. And so our key takeaways from this are really that, 1, disparities in incidence appear to have narrowed, but were still present in 2017. And excuse me, there was a disturbing pattern of disparities in healthcare utilization, which is that Black beneficiaries are more likely to receive higher intensity, lower value care, like being hospitalized or spending longer durations in skilled nursing facilities, and less likely to receive very high value care services, like receiving medications to treat Parkinson's disease, occupational or physical therapy, or hospice services. And we hypothesize, because we've adjusted for a broad range of factors, that one of the key drivers behind this disparity is likely systemic racism, and that access to care and differential systems of healthcare delivery, as well as broader systems of structural inequity in society more broadly, result in Black patients having less of an ability to access care resources, and in receiving care that is not at the standard that their white counterparts would receive. And we also have to address, I think, the large elephant in the room, which is that a portion of this disparity probably is mediated by implicit or explicit bias and racism by healthcare providers and by folks that work within the health and social services systems. And a big part of our future directions, as we'll talk about later, is trying to parse out which parts of these disparities come from which mechanism. So now I'm going to move into our second topic, which really branches out from our current findings. And this was led by Margaret Goetz here, who is a wonderful member of our department, and I don't know if is on the call today. This question really is evaluating whether or not, specifically in the last year of life, there are racial disparities in the receipt of low value care. And that's care that is essentially high cost and minimal benefit, where patients in the health system are incurring large expenditures, but are not receiving meaningful and appreciable clinical benefits in return. And so this is a smaller study population, since we're only looking at folks who died between 2015 and 17, which is about 70,000 beneficiaries, the majority of whom had Alzheimer's and related dementias. And whose median age of death is a little bit larger than the general population, as older folks are more likely to die in any given year, and otherwise a relatively similar representative population. And we used a very similar adjustment strategy, again, controlling for some of the things we already know are key determinants of access and receipt of care. So let's first just take a look at this. So this shows overall percentage of patients who received various services. So it's first worth noting, and probably not a surprise to anyone here, that the rate of hospitalization in the last year of life is quite high among this patient population. And there's a great degree of literature debating about to what extent end-of-life hospitalizations are desirable and or preventable that I won't really get into today. But what we definitely can see is there is a striking disparity in the in whether or not patients are hospitalized in the last year of life based on race, which is that nearly 80% of Black patients were hospitalized in the last year of life, whereas that number was closer to 70% for white patients. And we also see that other measures that are, according to current guidelines in that exist either by from the American Academy of Neurology or often from the American College of Physicians as part of the Choosing Wisely campaign, are contraindicated in the last year of life due to providing no appreciable clinical benefit and incurring significant clinical harms and notably as well significant healthcare costs, such as non-indicated cancer screenings, placement of feeding tubes for patients with dementia, and peripheral arterial stenting. We observe that these outcomes are still fairly common with, for example, feeding tubes being placed in nearly 1 in 10 Black patients with dementia, and that the disparities in incidence are even wider. And so we then threw in our adjustment approach and found that, as you can see, this entire slide is bold because everything was significant here, and that's really concerning. We found that Black beneficiaries were much more likely to be hospitalized and were dramatically more likely to receive low-value care services. 72% more likely to receive peripheral arterial stenting, almost 3 times as likely to receive a feeding tube, more likely to be screened inappropriately for colorectal cancer, and less likely, again, to receive hospice services and occupational physical therapy services that have been demonstrated repeatedly to be not only of extremely high value to patients, but also to be extremely important in promoting favorable clinical outcomes. And so the key takeaway from this work is that there are major disparities that go beyond healthcare utilization more generally, but there's also a very concerning pattern where Black beneficiaries are more likely to get low value care that is not of clinical benefit and less likely to get high value care that is of clinical benefit. And again, we posit that there is a combination of systemic racism and individually mediated racism that probably drives some of these associations. And our future work will explore a little bit more about how we can get to the bottom of which of those mechanisms is driving which of these disparities and how we can go about meaningfully addressing that in the real world. So our next question looks at race and sex disparities in the receipt of psychiatric medications, and this was led by Kim Johnson. And so this question looks at patients who had dementia in 2017, which was about 124,000 patients, who were average age of about 80, and otherwise, again, a relatively similar population as described before. And we looked at what medications were these patients prescribed, and how did the rates of medication prescription differ by race and sex. And so as you can see here, among beneficiaries who were diagnosed with anxiety, depression, and psychosis respectively, we can see that male beneficiaries were much less likely to be diagnosed with anxiety than female beneficiaries, less likely to be diagnosed with depression, and slightly more likely to, roughly equivalently likely to be diagnosed with psychosis. And in race, we see a trend that likewise shows that Black individuals were diagnosed less frequently with anxiety disorders and depression, but more frequently with psychosis compared to their white counterparts. And so we then looked at trends in the medication prescription for these patients. And the first thing is to say that this study sort of highlights a little bit of a different observational data approach, which here we're primarily describing existing trends to help us understand what's going on in real-world clinical practice from the data that we have based off of what patients actually fill at the pharmacy and assess that their Medicare Part D benefit. And we found that the overall use of psychotropic medications in this patient population, unexpectedly, but perhaps concerningly, is actually quite high. More than 1/3 received anti-anxiety medication, the majority of which were benzodiazepines. More than 2/3 received antidepressants, and more than 1 in 4 received antipsychotic medications. And again, there was a concerningly high rate of benzodiazepine use among a patient population for whom these medications entail very substantial risks. And we also observed that there were higher rates of use for anti-anxiety medications among female patients diagnosed with any neuropsychiatric comorbidity compared to male patients. And we also observed that anti-anxiety medications were more frequently used among white patients, but antipsychotic medications were more frequently used among Black patients. And so these findings are also, again, are preliminary and descriptive, but give us some room to pause and ask whether or not our current clinical practice ecosystem is operating in a way that provides equitable care to all patients. And there are meaningful and concerning differences, which are likely disparities, although we hesitate to use that language without knowing about whether or not patient preference plays a role in the use of these medications, which we cannot assess with our data source. It's clear that more research and action is needed to create this concept called pharmacoequity. For those of you who haven't heard of this, there's a really phenomenal paper in JAMA from last year by an excellent researcher named Utibe Essien, who has coined this concept of pharmacoequity, which essentially says that we ought to think about the prescription of medications in the same way that we think about other delivery of care services, and that we ought to strive to create equitable patterns of delivery of highly efficacious medications in order to ensure that patients can have equal access to favorable health outcomes that are driven by the use of those medications. And so there's a lot to unpack among this data, and we could spend an entire Grand Rounds presentation just talking about medication prescription in dementia, but we'll move on to our last question. But before we sort of move away from the disparities lens, which is where the majority of our work is focused, I do want to leave y'all with one last note that I think has really motivated a lot of our team's work, which is that some of the work we've done certainly has been describing disparities, but we also are really striving to understand the mechanisms. An analogy that I've heard used many times is, we, especially in the field of neurology, have spent decades identifying causative genes for conditions, understanding the neuropathological basis of the conditions that we treat in the clinic and on the wards, and developing effective medications to target the causative agents of conditions that we see. And we need to think about racism the same way, and sexism the same way, and other forms of bias the same way, in terms of we need to understand the mechanisms that create our unequal systems of care and unequal outcomes in the population, and build interventions to tackle those mechanisms to actively create health equity, as opposed to just hoping that it will magically happen if we all try hard enough. And so that is, I think, what a lot of this work is motivated by, and we're looking forward to continuing to advance that work. But I want to leave you all with a different blend or different focus of question using the same data set that we also did, which is very clinically directly relevant, and I think shows the power of using observational data to answer questions that are relevant for researchers and relevant for clinicians alike. And this was a very simple question, which is, do the electronic health record in Maestro Care that we have here at Duke, do our diagnoses of neurodegenerative disease correspond with the claims data that we have for Medicare, which come from all sources, including providers from outside the Duke system? And so what we did is we linked all of the patients who were Medicare patients in North or South Carolina from 2014 to 2017 and who had been seen at the Duke University Health System. And we identified those patients with neurodegenerative disease based on whether or not they had ICD codes in the encounter diagnosis table, billing diagnosis, or in prescription medication fills, and then calculated how sensitive and specific were Duke's electronic health records, which again only come from our health system, with Care Everywhere being a relatively limited way to access outside records, but by comparison. And how does that compare to Medicare claims data, which include all providers in both states? And this included around 102,000 patients. And what we found is that there's some really good news and there's some less good news. For one, our electronic health record were highly specific for identifying either dementia or Parkinson's disease. In fact, 99% specific. The bad news being it was only moderately sensitive. So to identify any form of neurodegenerative disease, we found that, we're missing a substantial chunk of patients. It's only about 60% sensitive to identify a patient with neurodegenerative disease. And these trends are stronger for dementia than they are for Parkinson's disease, which makes sense because we expect that dementia presents among patients. It's both substantially higher prevalence, can sometimes fly under the radar in clinical settings where patients are not receiving longitudinal care in comparison to Parkinson's disease, which tends to stand out a little bit more. And so we saw that for dementia diagnosis specifically, electronic health records were only 56% sensitive, but the sensitivity was much better for Parkinson's disease, being around 76% sensitive. And we also did a sensitivity analysis where we only included patients who had at least 2 encounters within the Duke system to account for patients who maybe only were seen once for a surgery or for a one-time specialist visit that may have been unrelated and may have not caused dementia to be captured in their electronic health records. And we found that the results were still pretty similar. So the take-home points is that, one, dementia and Parkinson's disease may not be detected very well in structured electronic health record data. And for those of you who are interested in using Slicer Dicer or Deduce or other forms of electronic health record data, that has implications, knowing that you may be missing patients who have neurodegenerative disease if that's the strategy you use to identify those patients, and that there may be selection bias, and that we don't know if those patients are the same as the rest of the patients who are having those diagnoses captured in their structured data. It's also possible, as I said before, that we may not be finding patients who have neurodegenerative diseases upon presentation for services such as outpatient surgery, where a patient may be coming to get a cataract surgery, and it may not be particularly perceived as relevant to the team to obtain a lengthy list of the patient's other medical conditions and to record that in the structured electronic health record. But it's worth noting there are obvious patient safety implications for failing to identify a diagnosis of dementia and Parkinson's disease. Patients with Parkinson's disease, for example, are at substantially higher fall risk, which is a leading cause of hospital-associated morbidity in the United States. There are concerns about providing patient instructions to patients with impaired memory, capacity to provide informed consent, and dealing with visitation guidelines and working with families. And it's clear that if we truly are failing to capture this patient population, that has implications for the kind of clinical care that we provide. So those are 4 questions, and I know it was very rapid fire. We didn't go very in-depth into any of them, but I hope that this has demonstrated the power of observational data to help answer questions and develop a deeper understanding of the mechanics that underlie the way that our health system works to generate the outcomes for the patients that we care for. On a systematic level as opposed to on an individual level. And so some of our next steps, we're looking forward to jumping into some work to generalize this to a national sample and to also consider the impact that structural disadvantage in neighborhoods has, looking at whether or not the conditions that folks live in and the communities that surround patients has an impact on outcomes. And there's already a growing body of literature, which has been led primarily by Amy Kind, which has shown that neighborhood socioeconomic deprivation is associated with the incidence of dementia. And it's actually a very strong predictor for dementia incidence, even after adjusting for other factors. And so we're looking forward to exploring that association. And again, to provide deeper mechanistic insight about what components of our societal structure and health system structure generate the outcomes that we see. So thank you, Slide. We have a huge list of fantastic co-authors who have been incredibly helpful throughout this process, including several members of the department who are listed here on this slide. Again, thank you to both Doctors O'Brien. Emily O'Brien is my third-year mentor, and it's been a wonderful research experience for me. So I've been thrilled to have the opportunity to share our research here at Grand Rounds. And I'll turn it back over and here's also contact information. Please follow me on Twitter, and Emily as well. We both are active in the scientific and medical Twitter. And if you are interested in seeing our thoughts on observational versus RCT data, you can certainly find that on Twitter as well, and as well as a contact here. And also, I'll turn it back over to Emily to talk a little bit about some opportunities to get involved with the Department of Population Health Sciences and some of the services that the department has on offer.
Great. Thanks, Jay. So I'll just very, very quickly go through this so we have time for a question or two. But so we have a data share in Pop Health that some of you may have worked with and are aware of. But just very quickly, if you go to the next slide, we have a lot of data available for use, certainly a lot of Medicare data, as well as additional claims data. The best way to find out about this is to go to our data share website. We try to keep an updated list of what we have available and some details about how to access that. If you go to the next slide, you can sort of see what the process, or okay, some details about the Medicare data specifically, which is what we use in this work and use often within the department. Lots of expertise from a statistics standpoint, a method standpoint, an administrative standpoint. We can offer a lot of different kinds of support if you're interested in using those data. And I think the next slide has our website. We also have a few specialty cohorts that I'm happy to provide more information on if needed. But just Google Duke Pop Health Data Share and you'll find it, or go to our website and there's a link on the homepage that'll direct you to more information. So we'd love to work with you.
Thank you both. It's a pleasure, and I think this is an important area. I'm going to co-opt Jim's question, Jim Burke, and generalize it a bit. And the question is, how much does, we'll say, income, education, and especially geography confound this data?
Yeah, absolutely. So it's a great question. And I love that question we've received presenting this work at national conferences and elsewhere is always the first question we receive. And it's a really great question. And
insult or a compliment, Jay?
It's absolutely I think it just goes to show, I think, with the way that we conceptualize the concept of race in America. Race, as we recognize, is an artificially created social construct, not a biological reality. And income and race, because of the history of systemic racism in this country, are closely intertwined. And so it can be difficult to separate out what mechanisms derive from one component and what from another. The work that we plan on doing, that we're about to embark on, we hope, is really trying to directly answer that question, which is saying, does accounting for neighborhood socioeconomic deprivation, which includes things like income, education, the attributes of a community, such as access to critical infrastructure, explain the association? And the answer to the question for neurodegenerative diseases is we don't know. Although we do know that individual income probably does not explain very much of this association from what we've seen in our current data, although that's a relatively limited metric, all things considered. I do want to say some of the work that we've done in other disease states, and we have active work being done that I've been working with another member of the department, which is Brad Hamill, has shown that for patients with other neurological conditions other than dementia and patients with cardiovascular disease, pulmonary disease, renal disease, diabetes, that ultimately neighborhood deprivation and race independently are associated with worsened outcomes. Even if you account for differences in income and economic deprivation, we still see disparities based in race. And we see disparities among patients of the same race based on their neighborhood socioeconomic characteristics. And so I think ultimate answer is that these are closely intertwined topics, but almost certainly independently contribute to the outcomes that we see.
I don't know about neurodegenerative diseases, but in a lot of other outcomes, if you separate it, it's much more race than it is any other factor. So someone in the upper 20 percentile of income who's Black will often have like worse outcomes than someone who's in the lower 20% for white.
Absolutely, and we've seen in some of the preliminary data we have, again, not focused on patients with neurodegenerative disease, we've seen similar trends. And so we're looking forward to exploring this question and providing some additional mechanistic insight for patients with neurodegenerative disease. And we'll be glad to share that with folks once that we have that kind of data.
And what's that saying, when you find yourself up to your eyeballs in alligators, you've forgotten that you came to drain the swamp? This work, my original interest in this work is dementia way underdiagnosed in the community as opposed to in epidemiologic studies? And the data basically suggests that it's not, that if you look at epidemiologic studies, the prevalence and incidence of dementia in North and South Carolina kind of match up, which I found was surprising. Do you want to comment on that?
Yeah, I can comment on that. I wonder if Emily has additional thoughts on this as well. The question about incidence calculation with claims data gets into a very thorny space very quickly, because it can be very challenging to determine to what extent claims data captures what happens in the real world. And that's, again, talking about some of the skepticism that Dr. Bryan had mentioned earlier, which is that it is challenging to figure out to what extent a difference is driven in incidence is driven by coding patterns versus actual differences that happen in patient population. I think what we perhaps are seeing is that there's probably some patients who are getting these diagnosis codes who probably don't actually have neurodegenerative disease. And there are almost certainly patients who are getting these diagnosis codes who do have neurodegenerative disease and who are not being included in data. And I think there is a pretty broad research landscape in the coming years that will evolve to figure out how can we identify those patients without going into the clinic and seeing them ourselves and performing rigorous assessments to determine if they meet clinical guidelines. To do even a very limited validation is extraordinarily time consuming. And we've seen that from some of the previous work that has been done with validation cohorts. I don't know if Emily has other thoughts on that question as well.
No, I think that's a really good summary. I mean, it was surprising to us too, Rich, and I think it in some ways, as we think about defining incidence, acknowledging the issues with underdiagnosis, acknowledging the issues with access to care, acknowledging the issues with billing patterns that vary from one system to the next. It really is about trying to come up with a cohesive picture of what incidence and prevalence really is, using information on cohorts which we know are selected, as well as claims data and EHR data, rather than any source being really the one truth, so to speak.
Yeah. Well, first of all, I want to thank you again, and let's hope this is just the beginning of a long-term interest in these diseases. And the Department of Population Health, and both Emily and Jay. Jay, we welcome you back to the wards. I will say, in my entire career, the most nervous I ever was about medicine was the day I came back to the wards from doing my PhD, because I thought I was so out of step and had lost everything. And I was taught very quickly that if you're just nice and work hard, everything is fine. You don't have to be all that experienced. And I think everyone on the Zoom who's a physician knows that. And just be nice and work hard, and hopefully you'll decide to stay in Durham and at Duke in the future. So thank you, Jay. Thank you, Emily. And thank everyone else. And have a great day.
Everybody.